just to double check, this is the GLP-Agonists breakout group. Make sure you're in the right room. Otherwise, I have no idea how to help you get to the other one. But I'm sure there are people who can help you. So hello again. I'm Deborah Matthews. I have the pleasure of moderating this session. Just to give sort of a frame of the overall goal of this, and you probably got a sense of this from the presentations you heard this morning. CESTI worked through cases. That was the mode of operation. And as I described earlier, we developed this heat map as a tool. But that heat map hasn't really been pressure tested as yet. I mentioned that there are a number of remaining questions about it. But we think it really could be a valuable tool. And this is an opportunity to use that tool to work through a particular case that wasn't part of the original CESTI or STI work, right? So taking into account what we heard this morning about the goals of STI and where Victor and the rest of us are trying to take this work, we selected two cases, GLP agonists for weight loss as one of them, to really help us get concrete and take what we talked about this morning and apply it to an actual case of a technology that's having a huge impact right now, but it's still quite early in its trajectory. And so maybe we can think about how to shape the direction of the technology going forward. So first, I'm going to turn to the panelists and ask them to briefly introduce themselves and share any directly relevant financial or relationship disclosures in a sentence or two, so everyone knows who we are and where we're coming from. And then I'll talk briefly again about the CESTI heat map, and then I will turn to Bill Dietz for some remarks on GLP agonists. So Bill, if you could please briefly introduce yourself and make any disclosures you have to make.
Good afternoon. I'm Bill Dietz. I'm the chair of the Redstone Global Center for Prevention and Wellness for at least 6 more weeks, and director of the Stop Obesity Alliance at GW. And prior to coming to GW, I was the director of the Division of Nutrition, Physical Activity, and Obesity at the CDC.
Good afternoon. My name is Michael Knight. I'm a clinical associate professor of medicine at the George Washington University and head of services at Impact Care. I'm a clinician, researcher, and health equity speaker. I have done consulting in the past with Novo Nordisk.
I'm Joe Naglowski. I'm president and CEO of the Obesity Action Coalition, which is the patient advocacy organization in this space. I don't have any personal financial relationship, but my organization's the Obesity Action Coalition takes support from most of the evidence-based obesity care market. The other disclosure I'll make is I am a person living with obesity who is benefiting from one of these medications.
Hi, I'm Sharika Kuanyika. I don't have any disclosures. I am an emeritus professor, University of Pennsylvania, and a research professor at Drexel University School of Public Health. And I have spent several decades working on obesity issues with a focus on Black women. And from the point of view of reflexivity, I am in that group that I have been studying.
Terrific. And again, I talked about the heat map very recently, so I don't feel the need to go through that in any detail. But I'll invite you to look for folks who are in person. We have a paper attendee packet in front of us, and you can find the heat maps in there. And for folks online, this is also available in the attendee packet that is posted on the streaming page. And I'd invite you to think about, as you're listening to Dr. Dietz's remarks and the panel before we turn to the Q&A with the audience, to think about the overarching principles, the different sectors of deployment, and how this particular technology is playing out differently in different sectors and for different actors. And with that, please.
Well, thank you, Deborah. And is this not working? I'm sorry, is this not? Thank you, Deborah. And I forgot to mention that the Stop Obesity Alliance is supported by something like 40 different organizations and individuals, but I receive no salary from that group. So it's today I'm going to talk about I'm going to begin with describing the prevalence of obesity and the disparities associated with obesity, the role of GLP-1 agonists, and how the GLP-1 trials have been populated, and talk about the differences in drug metabolism in people with obesity, which has been largely ignored in discussions of obesity, and close with some brief comments on the impact of this new drug technology on the ecosystem of obesity. But the bottom line for me is it's hard to think of any other disease that has demonstrated the effects of inequities as a consequence of drug development, and the whole system is permeated with those disparities and inequities. Let's see. So I wanted to begin by sharing with you the changes in obesity over the 50-year or 45-year period shown here. As you can see from this slide, every age group and both genders had parallel increases in the prevalence of obesity beginning in about 1975. And this is a really important slide because it demonstrates that there are not individual contributions to obesity, that this is a consequence of some undiagnosed or unrecognized change in the environment. And this difference may also affect the differences in prevalence by minority groups who may or may not have had the same kind of increase in parallel, or whether their trajectory differs from all of this. But the one conclusion that you can make from this slide is that obesity in the population is not a consequence of individual behavior changes. This is a consequence of some environmental determinant. This is also true for children. I'm trying to get this to work. Oops. This is also true for children and adolescents, and you can see here the changes beginning in, again, about 1975 with an acceleration of those curves. But these curves by age group are parallel. So again, this points to some kind of common exposure, common determinant across populations. Oh my goodness, I'm certainly having difficulty advancing these slides. Deborah, okay, I might need your help here. Oh, thank you. So this shows the prevalence of obesity by age, gender, and ethnicity in 2 to 19-year-olds. And these are data from the National Health and Nutrition Examination Survey 2017-2018. And you can see in the left-hand curve that the prevalence of obesity, interestingly enough, is increased in boys more than girls. There's obviously difference and a disparity in the gender-related prevalence of obesity. And on the right-hand slide, you can see that there's clear ethnic differences. So NHW are non-Hispanic whites, NHB are non-Hispanic blacks, NHA are non-Hispanic Asians, and Hispanics. And you can see that there are already very significant disparities in the prevalence of obesity in the black girls. And also, surprisingly enough, and inconsistent with that observation, is the increase in prevalence in Hispanic boys. This shows the prevalence among the adult population, and in contrast or consistent with the pediatric observation is that the highest prevalence is among non-Hispanic black women. There is a differential among men, that there is a higher prevalence among non-Hispanic whites and a higher prevalence among Hispanic men than there is among women in these groups. And again, it's important to recognize that these racial differences are not due to differences in intrinsic factors like genetics. These are clearly a consequence of the environment that accounts for these differences, not biological differences in the onset. So turning now to the GLP-1s, The GLP-1 is a gut hormone, and I think many of you are aware of this, and they act as a receptor agonist to increase pancreatic insulin and decrease glucagon release. There are additional effects that are quite relevant and account for a number of side effects, include decreases in gastric emptying and increases in satiety. Again, that latter is attributable to both gut and brain effects. And the two most recent drugs approved for people with diabetes and obesity are semaglutide, which is a GLP-1 agonist, and tirzepatide, which is a combination of GLP-1 and glucagon increasing peptide. These drugs are both approved for, different drugs within these categories are approved for diabetes and weight loss. And it's important to recognize that under semaglutide, it's the same drug, but what accounts for the difference in diabetes and weight loss is a difference in the dose of that drug. It's important to recognize that these are very expensive drugs, and they require weekly injections and a gradual buildup over time, and that the consequence of these drugs is weight loss over a period of a year to a year and a half, followed by weight maintenance if the drug is maintained. It's also important to recognize that these drugs really represent a huge shift in our ability to treat obesity. So you can see here that semaglutide and tirzepatide both have significant numbers of people who have weight losses over greater than 20%. So 30% of people on semaglutide, 57% of people on tirzepatide. And by way of comparison, I've listed the one study of the effects of Roux-en-Y metabolic surgery and sleeve gastrostomy metabolic surgery. And you can see that we're not there yet. We don't have the same impact of drugs as we do on surgery, but we're getting closer. And it's likely that the number of drugs in development are going to bring us even closer. And so moving from the relatively modest impact of behavior modification, which accounts for about 5% of weight loss in the best studies, to now 57% of people losing greater than 20% of weight loss, that we're displacing or getting close to displacing the reliance on metabolic surgery. And the other point to make about metabolic surgery is that its impact is relatively small in terms of populations. About 1% of the population with obesity have bariatric surgery. Now, there are a number of disparities related to obesity medications in people with obesity. One of the most notable is that people with obesity are excluded from drug trials, there's an effort to develop a homogeneous population, and under those circumstances, that's not defined as a population which includes people with obesity, which is a huge omission because 42% of the adult population, 20% of the pediatric population have obesity. Blacks and Hispanics have been underrepresented in GLP-1 trials, and I'm going to show you in just a minute that these obesity drug trials fail to recognize the emotional, economic, or contextual factors related to adherence. So these are two studies, very recent, which show the disparities in sex, race, and BMI and obesity medication trials and medication usage. So in the first study, participation in clinical trials of 12 obesity medications were assessed over about a 14-year period, and over almost 250 RCTs, 1 million plus participants with and without diabetes. Women over the age of 40 with obesity class 1 and 2, which means 30 to 34.9, 35 to 39.9, were the major targets of these interventions. People with severe obesity, 8% of the adult population, were not included. Furthermore, these studies under-recruited older participants, those with class 3 obesity, as I just mentioned, and non-whites and males. And a second study of the usage of these medications found lower rates of GLP-1 agonists among Asians, Blacks, and Hispanic patients with type 2 diabetes, and that there were higher rates of usage among females and higher zip code linked household incomes. So now we have evidence that that both the medication trials related to medication usage, as well as the actual usage of these drugs, is clearly associated with disparities. And as I said, I think that this increases the likelihood that the disparities may actually widen as they're effective. These drugs are effective in upper income and white populations and not being used to the extent possible in Black or Hispanic populations or Asian populations. The other important element of these drug trials and recognition of these drugs is that obesity is a highly stigmatized condition. I think you'll hear more about this from the panel. But interestingly enough, almost 50% of people believe that using GLP-1s for weight loss prioritizes the appearance of prioritizes appearance over health, not medication or not health usage. And 60%, interestingly enough, have more respect for people who lose weight without medication. Again, this very prevalent bias about drug use and its impact. And about half of people say that people using GLP-1s are taking, quote, the easy way out, so that there's also this bias about people on drug therapy, despite the fact that it's a very effective tool. So coming back to this, the fact that obesity drug trials are limited to a predominantly white population means that these trials don't fail to recognize the emotional, economic, and contextual factors related to adherence. So that our drug use and attitudes toward it are based on a very narrow population. And that furthermore, we know that medication access is inequitably distributed, that people with health insurance, people with money can get the drug, and people of lower incomes who may not have health insurance, but who have a greater need in terms of these medications are not receiving the medication. The final point is that the lipophilic drug pharmacokinetics in people with obesity have been widely ignored. And this is a nice study of IV diazepam and the plasma diazepam levels. And on the left, you can see the effect of these medications on a control subject, in which VD, the volume of distribution space, is 107 liters, and the half-life is 51 hours. However, in subjects who already have obesity, the volume of distribution is much greater because of the adipose tissue. And as a result, because even after the drug is discontinued, there's slow release over time, so that the half-life is, as you can see, is almost 5 times greater among people with obesity than not. And another indication of the kind of differential treatment of people with obesity is these drugs, I should say, lipophilic drugs, include commonly used drugs like antihypertensives, like statins, like chemotherapeutic agents. So this is not a trivial concern, and yet the package inserts or providers are unaware of how these drugs are different and what impact the lower concentration of these drugs may have on therapeutic outcomes in people with obesity. So as I said at the outset, this is, I think, one other point. This is a roundtable of obesity drivers and solutions that the Roundtable on Obesity Solutions here at the National Academy of Medicine developed. And you can see this is a very complex system. And the point of showing this is not to walk you through it, which took us a long time to develop, but rather to show you the complexity of the system and the likelihood that changes in one element within this complex ecology can change a variety of other elements in this ecosystem. And we have no idea what kind of implications or what kind of consequences are going to be attended by the increased use of these GLP-1s. Oops. So in summary, the new GLP-1 agonists have already transformed obesity care. They're in wide demand, wide use, and in fact, the demand exceeds the supply. But with time, I would assert that these drugs are going to alter the entire obesity ecosystem in ways that we don't understand. The stigmatization of obesity is pervasive and likely affects every element of care, including the development of drugs and their application. That participation in obesity trials and the use of obesity medications are associated with racial and socioeconomic disparities and inequities, and as a result, as I said, these disparities and inequities are likely to increase. And because drug trials have been limited to the physiologic responses and outcomes and have excluded populations, significant populations that have been disproportionately affected by obesity, we have no information on how factors like race, culture, socioeconomic class, and others affect the effects of medications and therapeutic outcomes. So relevant to the discussion today, how can we design drug trials and implement the application of new groundbreaking medications in ways that achieve fairness and collective and address the individual good? Thank you.